In Chris's amazing presentation, we saw evidence of maiming and death. What Dr. Ross and I are going to talk about now is a more subtle form of maiming that we see in our trucking cases, traumatic brain injury, ranging from mild to moderate. Let me introduce Dr. David Ross. Dr. Ross is director of the Virginia Institute of Neuropsychiatry, an outpatient clinic specializing in treatment of patients' traumatic brain injury and other neuropsychiatric disorders. Dr. Ross will speak about proving TBI, traumatic brain injury, objectively with MRI brain volume measurement. In other words, you can see it. This is game-changing evidence for us. After Dr. Ross's presentation, I'm going to talk about encountering and winning a legal challenge to this evidence if you get one. Dr. Ross.
Let me set up my little clock so I try to stay on time. There we go. Thanks, Lee, for that kind introduction. I've had the chance to work with Lee over the past year or two. We've had a patient, my patient, his client, that we've done work on, a patient with chronic, mild to moderate traumatic brain injury. And I've enjoyed working with him, and I can understand why he's the super lawyer in the D.C. area. He's a great lawyer, great with Daubert, which he'll be talking about, and also becoming a good friend. So thank you, Lee, and thank you to the organizers of the conference for inviting me. Some hard acts to follow. I've been to many, many medical conferences and actually several conferences with attorneys over the years. This is one of the most interesting ones I've been to, and I mean that in a good way. There are a lot of hard acts to follow this morning. When Kent Spence talked, he asked us to raise our hands if we were plagued by the doubter voice, and I was afraid to raise my hand because I was afraid what people would think about me. But I'm going to go ahead. But I'm going to go ahead and give this talk anyway. And we're talking about proving TBI objectively with MRI brain volume measurement, as Lee said. And you know, many, many of my cases are probably cases all of you have had. A patient who's in a motor vehicle accident, about half of my patients have a big truck that's hit them. And afterwards, they have chronic symptoms for months or years or the rest of their life. We're mainly talking today about mild to moderate traumatic brain injury. Half of my patients never work again. They're so impaired. Then they have the lawsuit to try to recover their lost income, pay for the medical expenses, etc. And I diagnose them with traumatic brain injury. And then the defense expert doctors, they say, well, this patient didn't have a traumatic brain injury, and if she did, it cleared up in about a month, because most of them clear up, so therefore hers must have cleared up, and she was malingering on the neuropsychological testing. And you know how that goes. And up until about 5 years ago or so, the jury would be sitting there wondering, well, who's telling the truth? And they're not sure, and they might think, well, the defense expert has a nicer tie than Dr. Ross, maybe I'll go with him. That's where we're stuck. Well, nowadays it is so dramatically different because we have several techniques, technological advancements that help us understand the truth. And I share the passion you all have. As you know, my job is to tell the truth. Your job is to prove the injury, slightly different, but these techniques tell the truth. They're objective. So if the defense experts were to do the same brain volume testing I do, they would get the same answer. So that's what I want to tell you about today. And first of all, I want to tell you about NeuroQuant, which is FDA-cleared software for measuring MRI brain volume, major breakthrough in neuropsychiatry and brain injury medicine. And this is an MRI coronal slice, so it's a slice through the brain about like this. I like to think of this as if the patient is looking at you, so their right ear is on your left side of the image and their left ear is on the right side of your image. And then NeuroQuant will, the computer software will turn this image into one that looks like this with the different brain regions colored. And with our modern 3 Tesla MRIs, the more powerful MRIs, we get these very high resolution, beautiful images. And not only are the brain regions colored, but the brain volume is measured. And it's done automatically in about 15 minutes, which is an amazing breakthrough. This technique is based on over $100 million of initially National Institute of Health funding and research. And then NeuroQuant, the company, has developed it independently since 2006 when it was approved for clinical use. Now we built our software on top of that. First, let me show you a couple examples of the NeuroQuant reports you get. You get examples of the brain segmentation, we call it, and then the brain volume is measured and compared to normal controls. And I'll zoom in, I'll zoom in a second. This is the other NeuroQuant report we get. You can see a couple brain regions are abnormally small, a couple are big. This is basically a normal pattern. So, and we do a lot of research with our normal controls. And this is where I'll zoom in so you can see better. So now in the modern NeuroQuant 2.0 era, we have 39 brain regions, left side and right side, so that's a total of 78. It's a rich amount of data. And this person had abnormally small right amygdala below the second normative percentile, and these regions were big. So that's how you look at these reports. And because you have so many brain regions nowadays, and this has only been the last year or two we've gotten to this point, these are all cortical gyral regions right here. That means all these gray matter regions all over the brain. We're measuring each of them, the volume of each. And a lot of these have fairly specific functions, so we're at the point where we can start to associate specific impairment of the patient with the brain volume measurements. That's only been the last year or two we've really been able to do that very much. Then we come to NeuroGage, which is the software we've developed over the past 6 years at my center. NeuroGage is built on top of NeuroQuant, and whereas NeuroQuant measures brain volume, NeuroGage extends its utility in several important ways, including brain volume change over time and brain volume asymmetry, critically important for assessment of the effects of traumatic brain injury on the brain. Here's an example of a NeuroGage cross-sectional analysis. Cross-sectional means one point in time. And we have left side of the brain, right side of the brain, and an asymmetry index, which is how big is the left versus the right. This is something NeuroQuant doesn't have. You can see here, for example, the lateral ventricle is abnormally asymmetric, with the left side being abnormally bigger than the right. And you get a lot of asymmetry in traumatic brain injury. This is an example of abnormal asymmetry that you can see. And I'll let you look at that and see what you think about the abnormal asymmetry. I'll explain in a moment. But to put it in context, about 5 or 10 years ago, patients with chronic moderate traumatic brain injury, people thought the brain looked normal. If you look at the brain images, even high-resolution MRI, it usually looks pretty normal for the most part. But we found out when we started measuring it, it wasn't normal, including asymmetry and longitudinal change. And we published 10 papers on this, peer-reviewed papers, in the past 6 years. And we've shown clearly in my mind that chronic mild to moderate traumatic brain injury, these patients do not have normal brains. You just have to measure it, though, to see this. So, for example, and this is one of my patients, mild TBI in a motor vehicle accident. These are the lateral ventricles here, these dark purple structures. Again, this is the left side of her head, right side of her head. The ventricles contain cerebrospinal fluid, and it looks like the left one's bigger than the right. Well, there were 3 radiologists looked at this MRI. There's actually 3 MRIs close in time that looked pretty similar to this one. All 3 said that it was the brain appeared completely normal. One of the radiologists actually said the ventricles are asymmetric, but that's normal, which I thought was an interesting comment. Well, we measured it and found that the ventricles were highly statistically significantly abnormal, below the first normative percentile. In other words, less than 1 out of 100 people will have ventricles that are this asymmetric. And I asked a radiologist who's a friend and colleague of mine, very, very good neuroradiologist. And I said, how do you tell when the ventricles are asymmetric or not? Because all these radiologists are saying they're normal. He said, well, it's just that's how we were trained. It's just your clinical experience. I said, well, what's your cutoff for being abnormal? I mean, how bad can it get before you call it abnormal? He says, what do you mean if I measured it? I said, well, how do you do it? And then what if you did measure it? He said, well, we don't measure it, but if I measured it, I would go look it up somewhere. I said, well, I did measure it, and I can tell you it's about 25% in middle-aged adult. 25% asymmetry is the cutoff for abnormal asymmetry. So, and you can see asymmetry when it's about 15 to 20%. That's when the human eye can start to detect it. This was probably 30% or more asymmetry in this case, I think. And so, in other words, you can have a little asymmetry that you can see, but that doesn't mean all asymmetry is normal. So the radiologists, they still really don't know, and I'm hoping my colleagues will catch up, and I talk to them whenever I can about this. There's one other area asymmetric here. If you see this golden greenish structure, that's the hippocampus, very important for memory. It's so small on the left you can barely see a trace of it here. That was also highly, statistically significantly abnormal, not mentioned by any of the radiologists, and I thought probably a cause of this patient's problems with impaired memory. And so based on that idea and other similar observations, we published a couple papers called our man versus machine papers, where we showed that NeuroQuant and NeuroGage, our software, could identify abnormalities in 95% of patients with chronic mild TBI, whereas the radiologists, based on their old-fashioned simple visual inspection, only identified abnormalities about 12% of the time. Then we come to something probably even more important, that's the longitudinal analysis. Critically important to measure change over time. That's true in science, medicine, economics, all sorts of things, and it's true in brain injury. And to give you a very simple example, because even though it's true and most people sort of know it, it's easy to forget about, I've found. So you don't want to forget this. A simple example is my incredible shrinking man analogy. If I had a patient who came into my office and said, Dr. Ross, I think I'm shrinking. I'm only 5 feet 8 inches tall. And I measure his height. Sure enough, he's 5 foot 8 inches tall. I say, but that's perfectly within the normal range. You don't have to worry about that. And then he says, well, 1 year ago I was 6 feet 2 inches tall. Then I said, oh, well, that's a completely different story. You shrunk 6 inches in 1 year. You've got something terribly wrong with you. That's the power of the longitudinal design, because you're comparing each patient's baseline to themselves at a later date. Way, way better way to do it, including for brain injury. This is another way of looking at the same thing. This is plotting cerebral white matter volume versus the age of a teenager in this case. By the way, I took this graph from our sports concussion work, but that's still brain injury, so it works perfectly well for what we're talking about today. But this is a hypothetical graph of a football player before and after the season, 4 months season. And his brain volume at time 1 is normal. Upper range of normal, but still normal. His brain volume at time 2 is still normal. Lower range of normal, but normal. And if you draw the line connecting them, you'll say, well, it went down. Seems like it went down a lot, I guess, but did it go down at an abnormally fast rate? That's the critical question. You cannot give the answer to that question looking at this graph. That's where we've been stuck with NeuroQuant. But with NeuroGage, we give you the other graph, which is plotting the change over time. So I have a different axis. This is brain volume change over time. When you do that, you find he's below the abnormally low cutoff for having abnormally fast shrinking of the brain over the football season, which, slight digression, a significant number of high school and college football players and ice hockey players have significant shrinking of their brain over the season, even when they never have a full-blown concussion during the season. They're called subconcussions. Very important. But that's another story. Back to our patients in my clinic with chronic, mild to moderate TBI. Here's an example of a NeuroGage longitudinal analysis. Pretty much the same thing, again, looking at it in a little bit different way. Now we have many, many brain regions here, and you can see that many of these brain regions shrink abnormally fast. For example, this patient's whole brain shrunk at the rate of 7.36% per year, which was faster than about 99% of what normal people would be expected to shrink. And this is a fairly typical example for a chronic mild traumatic brain injury patient. Okay, so now I'm going to end up with some practical recommendations. Having given several of these talks over the past few years, I find I get similar questions, so I'm going to go ahead and answer the most common questions I get after a presentation like this, which hopefully will be helpful to you. So what you want to do, if you have a patient with chronic mild to moderate traumatic brain injury, and you want to assess whether the brain was affected and whether the volume was affected. First of all, I think you should do brain volume measurement. There are several techniques. Many are very, very good. In my opinion, brain volume measurement is the best for various reasons. This is based on FDA-cleared software, unlike the other techniques, which are not really. This is a simple concept for people to understand. The brain shrunk. Sounds bad, is bad. That's what it basically boils down to. And so, you know, I mean, I may be unconsciously biased, but if I am, I don't know it. But you got that one, good. But you should be getting this on all your patients like this, and it's pretty convenient to get. So I'll talk about practical issues. First of all, where does your patient go to get an analysis like this? Well, he or she would go to their local MRI centers. Probably about 90% of current MRI scanners can do neuroquantable, neurogageable MRIs. They don't have to come to Virginia where I am, but you do have to make sure that the radiology technologist sets up the scanner exactly right. Every one of these little buttons has to be set exactly right. So it's not really hard to do. They just have to know to do it. Go on the website, look it up, and we can help teach them how to do that. We do that all the time. And then the radiology center will send us the brain MRI images, either on disk or, they could Dropbox it or something. They usually like to send it on disk. So those are sent to us in Virginia, where we do the brain volume analyses. Here's the NeuroQuant reports that I was showing you. We take the NeuroQuant data, we inspect the brain images, take the data, and then we do the additional analyses I was telling you about. And you see that all this is done in two locations. One, local, where you and your patient are, and two, at our center. So the patient never has to come to see me. I can do the brain imaging part without seeing the patient, in which case I'm functioning kind of like a radiologist. They usually don't see patients. They see brain images. If I do that, I have some limitations. I can't diagnose a patient I haven't examined. I also do the other traditional forensic exam, head to toe, examine the patient. And I do that too, and I can do both, but I don't have to do both. I can do just the brain imaging part if you want. Next, we talk about when to obtain the neuroquantable MRI. Greg, I sent you an updated slide set that had one slide that's not in here that I really, really want to show them. This is the older slide, slightly older slide set. Do you happen to have the newer one? While he's pulling that up, I'll just start explaining it verbally. So the question is, when do you get your MRI? Well, remember I said longitudinal, change over time. That means at least 2 MRIs. So the question should be, when do I get my at least 2 MRIs? All right. The first one, the best time to get the first MRI is the day before the accident. And since you can't do that, of course, get it as soon as you can after the accident. And literally, I would get it the day of or the next day if I could. We've never been able to do that as hard as we've tried. It's usually probably a month after the accident is the soonest we've been able to do it. If by chance you got it in the first week or two, you may be talking about brain swelling. That's a little bit of a different story. It'd be great to measure brain volume then, but call me because we have to talk about how to do that. But almost every case I've done, it's at least a month later by the time we get them in there for the MRI. Okay, I can get it from here. Thank you. Appreciate that. Okay, and so then the answers to the questions about when to get it are basically in this graph. This is the graph that I really wanted to show you. And believe it or not, this graph kind of summarizes the last 6 years of work I've done and probably 30 years of work done before that on MRI brain volume measurement and mild to moderate traumatic brain injury. So there's really a lot here, and I took this mainly from our Back to the Future paper, where we estimated brain volume the moment before injury based on intracranial volume and age of the subject, and then measured it afterwards, and we're the first ones to be able to draw out the atrophy curve here. In this case, it's cerebral white matter volume percentage change cumulatively. And I picked cerebral white matter because it's the most sensitive to atrophy. And we plotted out over time, months after the injury, and you can see there's very rapid shrinking of the brain in the first 3 or 4 months. It starts to plateau out, and by month 12, you have here is what's a linear change. That means it's a straight line. And so you want your first 2 MRIs in the steep part of the curve, right in there if you could get it, or at least in there. We are able to get some in there. And if you can get one there and one there, and that usually means about 2 months apart, then that is golden. You're going to almost always find very rapid brain volume changes, which is a hallmark of traumatic brain injury. The brain is shrinking so fast here, there's almost nothing else that would cause that except things that would kill you, like acute inflammatory brain disorders. Because we're talking rates of shrinking, 25% per year rate of shrinking. You can't blame that on, marriage counseling they had 20 years ago that the defense says caused all their problems. Because if the brain was shrinking at 25% per year, they would have no brain left after 4 years. They wouldn't be alive. So that's very helpful. But if your first MRI is a year or later, it doesn't matter so much when you get the second one, because the slope's going to be the same. Whoops, wrong button. Where'd it go? There it is. The slope here is the same. So at that point, you can get one here, you can get another one about a year apart. You'll still see the same rate of change, but after a good year, you're going to have more time for the full effects of the brain volume to occur. So in other words, to summarize that, for the time 1 MRI, get it as soon as possible after the injury. For the time 2 MRI, it depends. If your first MRI was within a year of injury, get the second one 2 months after the first one. If the first MRI was more than a year after the injury, get the second one a year after the first one. It takes a village, and this is my village that helps me with this work. And I appreciate your attention. I don't know if we have time for questions, but I'm happy to take any if you have time. Or you want to go first? Lee will go next, and then we'll take questions after that if we have time. Thank you.
So in addition to being the director of the Institute, and maybe once in your life talking to lawyers here today, is this the first time?
Not quite the first.
Okay. David is a clinical assistant professor at Virginia Commonwealth University in Richmond and is board certified in 3 areas: general psychiatry, neuropsychiatry, and brain injury medicine. And he's CEO of NeuroGage LLC, which produces NeuroGage, and that's the breakthrough technology we've been talking about. In our cases, we always look for ways to take the patient's injury and prove it outside of the subjective realm. That's really challenging in TBI cases, and this stuff will help all of us incredibly. It is a brain ruler and allows the doctors to measure and show why the person is having those memory problems, or maybe those concentration problems, or maybe problems with word groping, or isn't the person she used to be and can't work so much anymore because her performance has dropped off. So when you go to use these technologies, NeuroQuant and NeuroGage, in your cases, figure that a Category 4 storm is brewing on the opposing side. And figure from the very beginning of the case, you're in 4-down territory. So you've got to treat the use of this evidence with urgency from the time of your first encounter with a NeuroQuant, NeuroGage expert or even before, because the other side knows you're trying to take that case and show objective evidence that they don't have answers to, typically. So in other words, prepare for this evidence to be challenged with a motion to exclude it, and the opinions based on it to be excluded from the very beginning of your case. This technology can be powerful, it can be effective, it can be incredibly helpful to your client's traumatic brain injury case, but it's going to likely be challenged. Why? For those very reasons. It's powerful, it's effective, and it's helpful. So the same folks who make a lucrative living filing Daubert motions on us for any reason or no reason, had these same folks been around centuries ago, they would have filed a Daubert motion on Christopher Columbus in 1492 when he said there's a new world out there. They would have filed a Daubert motion on Copernicus in 1530 when he said the sun is at the center of the universe. So get ready to stand them down, and you can beat them. That's what I want to talk about. For years, the standard to be met for the admissibility of evidence was the Frye test. It's basically a test of general acceptance of technical, scientific, medical, and other specialized knowledge. The Frye test was superseded by Federal Rule of Evidence 702 and the Daubert case. Most states have something similar to Federal Rule of Evidence 702 governing testimony for expert witnesses. The elements are here. I'm going to sprint through some of these things, but the specialized knowledge, testimony of it, method needs to be helpful to the trier of fact, based on sufficient facts or data, reliable, and the expert reliably applied the method, principle, theory, evidence to the facts of the case. Daubert, which you all know, is a case that established a standard of scientific reliability for the admissibility of evidence from experts. And the Supreme Court set out a number of factors for trial judges to examine when deciding whether to admit evidence. And among these factors are these. Assess the trier of fact. Has it been peer-reviewed or published? And published. What is the error rate? Is it low? Are there quality control standards for the use of what we're talking about? And there you see general acceptance enters back into the picture. As a practical matter, look for general acceptance. General acceptance in the scientific or the medical, the technical community, and look for as much peer review literature as you can find. You'll win over the judge by doing that. Now, just because you retained a great expert and you're expecting a great report from that expert, don't deplane there. You have to work with the expert early to prepare opinions and prepare a report that is Daubert proof. So, anticipating you're going to need to be ready to encounter a challenge. Here are the nuts and bolts of what to cover in Daubert proofing your expert reports. These are sort of general guidelines, but you want to, again, look for peer-reviewed literature, get as much of it as you can, be sure the expert's got all the facts and all the data in your case. Make sure that expert can describe his or her methodology and how it's standard and accepted in the field. Fit is important. Make sure your expert has applied the method, the theory, the evidence, whatever we're talking about, to the facts in your case and can easily explain it. Again, these are general guidelines, so you can put these things in your expert report from the get-go and discourage any Daubert shenanigans by the other side. Ask your expert to put in a discussion of the use of the technique he's talking about. Say he uses it in his daily practice, and he's not just applying it to reach conclusions for a lawsuit. Have your expert rule in the substantial cause of injury, accident, brain injury, and rule out other possible causes, a disease process. Has the method been tested? Is there a retest reliability rate that's high? Is its error rate low? And again, is it generally accepted in that expert's field of expertise? If you're gearing up for a NeuroQuant specific Daubert motion, let me race through in 1 minute. Some of the points to include. All of this is in my material, so I'm just going to sprint through a few of these things. Oops, that's fast. But we're looking here. There's FDA clearance of NeuroQuant. There's peer review literature right on point. It's reliable. The findings the expert has concluded correlate with symptoms. In other words, the brain injury has led to a poor vocational outcome is one. Quality control procedures, as Dr. Ross said, his start at the MRI center, and they go all the way through the NeuroQuant, NeuroGage software checks and analysis of your patient, of the MRIs. Widespread growing use in clinics and radiology centers. Medicare coverage, there's a CPT code for what we're talking about. The rule-in, rule-out process, and it's proven to be objective, reliable, and a practical means of supporting that brain injury diagnosis and of showing a difference in volumetrics of the brain. So thank you all. We appreciate the opportunity to come before you, and I imagine there'll be more questions of Dr. Ross than myself. Any questions, starting with those for Dr. Ross? Sir.
On a previous presentation, they talked about a whole series of tests, functional MRI, and SPECT scans, PET scans, so do you go with all of those? Do you go with this? I mean, what's kind of the workup protocol?
Many of them are excellent. I like, again, back to my unconscious bias, I like the brain volume measurement as my go-to technique for the reasons I mentioned. Probably the second best one in my book would be quantitative diffusion tensor imaging, also an excellent technique. To do that, there may be 4 or 5 centers with a doctor at each center around the country that can do it. You may be talking, some of them the patient has to go there, like fly to Michigan or something. Some of them maybe not. And it's not cleared on the same FDA clearance level as NeuroQuant. But that'd be a close second behind brain volume. An advantage of QDTI is that there have been a lot of court cases where it's been accepted. With NeuroQuant and NeuroGage, we have 3 court cases where it's been accepted, no formal Daubert ruling yet. And Lee can tell you more about that if you want.
And there's been no serious court challenge to it either. They've been sort of challenged or objected to, but no serious attack on it yet that we know of.
So this would be your go-to methodology
I would start with brain volume, and then if you have the money and, you know, a budget to go and do more, I'd do QDTI next. That's how I would do it. And then if you have even bigger budget and want to do even more, you could consider some functional imaging technique, which is also very good. It's just, do you still need it at that point to make, you know, because you're probably, the chance with brain volume is 95% or more you're going to have probably more than one brain volume abnormality. The chance with QDTI is probably greater than 95% chance you'll have white matter abnormalities. Yes, sir?
How does the NeuroQuant and NeuroGage correlate with what you as a neuropsychologist used to do in getting the test and then writing a neuropsychological or psychiatric report to say that someone has brain damage? In other words, you did that for years before you got into this. I'm just saying, what do you find? It's better than doing those tests, and it really is more accurate with the brain volume and all that?
Yeah, and so I'm a neuropsychiatrist, which is a physician, and then I'll refer the patient to a neuropsychologist who's a PhD. They do the cognitive testing, very thorough, detailed. And in the old days, that was sort of what, they were kind of trying to be what NeuroQuant and NeuroGage are now. That's an oversimplification, not completely fair to them, but that's one way to look at it. But the problem with neuropsychological testing is great, I get it on every patient. But a limitation is it's not really objective because it depends on a patient's effort.
You can see this.
Right.
The other thing is this. Now, this just struck me right. But is your graph that was going down show that you have, it takes 2 years for the volume of the brain? I realize that was showing a percentage of how fast it went down.
Mm-hmm.
But I always learn with brain injuries, the person recovers as much as they're ever going to get in 2 years or 18 months. How do those things correlate? That's what I'm trying to do.
Well, we published on this, and a couple others have confirmed this, like Dr. Zhao and colleagues, that very fast decline in the first few months, the faster your brain, and Lee alluded to this, the faster your brain shrinks, the worse your functional outcome, meaning less chance you're going to return to work, less chance you'll return to normal social and family relationships, and the worse your cognitive ability will be. So we've got that correlation. And yeah, and there's another thing I was going to tell you and I forgot. I'm sorry.
And the beauty of this too is that it's not subject to opposing experts that say your client is feigning fatigue, is not given it at all, or has some repeat test syndrome, and all the things that make your ears bleed in these cases.
But the combination of the neuropsychological testing with the brain volume or other techniques is great, especially now that we can do all these little cortical gyral regions I showed you. We can start to correlate with all the different neuropsychological impairments, at least a lot better than we used to be able to do that. Thank you all.
Right. Thanks for your attention.